Hello and welcome to our latest Gastro Learning Live. We possibly should rename this Emerging Stars because it is with enormous pleasure to welcome Roos Pouw from Amsterdam, who really is one of the emerging stars of the whole area related to the assessment and endoscopic management of Barrett's esophagus. And so, Roos, really delighted to have you with us today. We're going to unapologetically address a whole range of issues in Barrett's esophagus. I'm mainly an HPB endoscopist, and Barrett still scares me. The things that scare me is misdiagnosing Barrett's from the start, missing dysplasia in Barrett's, less so the rest of it, because I think once we've, as a non-specialist endoscopist, if we can do those first two things, then you can go on to do the clever stuff. So we will talk a little bit about the clever stuff, but just start off, if you would, by telling us a bit about the diagnosis of Barrett's. Do we need clever scopes? Do we need to use weird solutions? Do we need to do chromoendoscopy? So it'd be really nice just to get that starter about how we diagnose non-dysplastic Barrett's.
Mm-hmm. Yeah. Thanks, George. I'm also very happy to be here and to chat with you about Barrett's for the next 30 minutes. Really nice. Thank you for the invitation. And I think what you're saying is really true, because a lot of endoscopists do Barrett surveillance, and of course, when you watch live endoscopy or see conferences, you're always shown these images of really, really subtle lesions that turn out to be ugly cancers. Yeah. So we get also our trainees are always afraid of missing something, and I think Barrett surveillance is really fun, and there are some really easy tips and tricks that will help you to do it in a right and easy way. And I think if you have sort of a standard approach to assess a Barrett's esophagus or any esophagus, that helps a lot. So what I always say is that if you know you're doing Barrett surveillance, it's really important to take just the best endoscope you have, because then, of course, you will see the most. And once you go in, what's really important also is to clean the esophagus. So before you start inspecting and seeing if there's a Barrett's or not, just try to clean up the distal esophagus, because there's always some mucus and bubbles or saliva, and just with your water jet, flush it off, clean out the stomach. And then you will have sort of a clean esophagus that you can assess with the best endoscope you took out of the closet. And then what I will say is try not to focus first on where the dysplasia is. Just try to see if there really is a Barrett segment, because
and I was going to say that you in your practice will probably see lots of patients referred in for the further assessment of Barrett's, and you have that perhaps slightly difficult conversation back with the referrers to saying, actually, this is a wiggly Z line, or it's just a small hiatus hernia. What are the tips, if you like, that you would bring to bear in making that initial endoscopic assessment?
Yeah, so the definition of Barrett's esophagus is actually that you have a columnar epithelium of 1 centimeter in your distal esophagus, and that it has intestinal metaplasia and biopsies. So what's really important is that you try to identify the top of the gastric folds and the diaphragm. And of course, the diaphragm is the thing that moves up and back and forth while the patient is breathing. And from there, try to see where the top of the gastric folds end, just play a little bit with your air insufflation and desufflation, because what you're saying, sometimes we get a patient referred with a 4 centimeter long Barrett's, but without intestinal metaplasia. And when we rescope, it's actually just a hiatal hernia of a couple of centimeters. And if you blow in a lot of air, that will look like a Barrett segment, starting from the diaphragmatic pinch. So if you just play a little with your insufflation and desufflation, you can identify the diaphragmatic pinch, and then see where the top of the gastric folds are. And then if you just have a very sort of a wiggly squamocolumnar junction, if it's less than a centimeter, we just inspect it really well. There's no need to take biopsies. And if you think there is columnar epithelium, then try to measure from the top of the gastric folds to the top of the columnar epithelium. And then we use the Prague classification, which you nicely see in the picture here, where you measure the maximum extent and the extent of the tongues of the columnar epithelium. And just take a little bit of time for that, because it can be quite difficult to identify exactly where the top of the gastric folds are. But if you take your time and remeasure, usually you will be able to do it. And also, if they're just really small Barrett segments or wiggly Z line, we know that the risk, even if there's intestinal metaplasia, the risk of progression to cancer in those patients is really, really low. I think you need to survey like 12,000 patients or 1,200, just to find one patient with cancer. So
to remind us again, so that's a patient who's just got small islands of intestinal metaplasia rather than continuous.
Exactly.
Yeah. Okay. And what about the patient who we see who's got nasty, what we presume to be reflux esophagitis? Does that, can you only really make the diagnosis of Barrett's after you've treated that esophagitis, or can you make it at the same time as the diagnosing the significant reflux?
Yeah, usually just really first treat the reflux, because you don't really know what you're looking at if there's still esophagitis. If there's a really bumpy lesion, then of course you should take a biopsy, but usually you really have the time, just put the patient on PPI and call them back in 6 weeks, because then the esophagitis is usually mostly healed and you can have a proper assessment. And also sometimes we get patients referred where the random biopsies are already taken. And if there's a lot of esophagitis, it's also difficult for the pathologist to tell you what they're looking at.
Okay.
So you always have some time to treat the esophagitis first. Yeah.
Great. We're going to move on to dysplasia in just a second, but biopsies in the whole areas of endoscopy now, where we're getting clever and we're not needing to use, not needing to take biopsies. Do biopsies remain mandatory in the diagnosis of Barrett's esophagus?
Yeah. I would say yes, still, because at least you need the intestinal metaplasia to be sure that there's Barrett's, because we know that that's the only type of metaplasia that increases the risk for dysplasia. We also know that even if you do very good inspection, a low-grade dysplasia is something you cannot always or most often do not see with the eye. So you really need the biopsies to know if there's low-grade dysplasia or not. And those are also patients at risk for progression. So I think you still need the biopsies to diagnose the Barrett's, and also sort of to stratify the risk the patient has to get progression.
Okay, fantastic. And then let's move to dysplasia. But as part of that, tell us about whether white light endoscopy is enough, both for the diagnosis of dysplasia of Barrett's, but also dysplasia. Should we in our practices be incorporating other techniques, chromoendoscopy, Lugol's, AI maybe? Tell us about that, and as part of discussing dysplasia and why that's important.
Yeah. So I think it's important to know what dysplasia looks like in the Barrett's esophagus. As said, low-grade dysplasia you will not see with your eye, but high-grade dysplasia is something you can see. And of course, early cancers are always visible lesions. Sometimes they're very clear, but most of the times they're just subtle lesions. It helps that if you know what you're looking for. So there are some modules available where you can train yourself in sort of knowing how early neoplasia dysplasia looks like, because can be a very subtle flat type lesion that's a little bit more red, or where the mucosal pattern is a bit disturbed, or just a slightly elevated lesion, for example. And if you know what you're looking for, you will find it more easily. And if you do proper white light inspection, I think most of the lesions you will find. Acetic acid is a dye-based chromo endoscopy you can use. If you use 2% and spray it over the esophagus, Barrett's mucosa, and let it sit for a while, you can get these areas that show loss of the whitening the rest of the Barrett's gets. And there are some studies that have shown that using acetic acid may improve dysplasia detection next to the random biopsies.
Because it's an area that scares and disturbs the general endoscopist, as you alluded to earlier. We go to courses, and the brilliant endoscopists such as yourselves, say, here's an area of high-grade dysplasia that needs to come off. I need to resect that. And many of the audience are thinking, oh, crikey, on my list, I would have sailed past that. Also, we just put up a slide that I think is yours about a sort of library or a teaching tutorial about detecting dysplasia. We'll maybe put that up again. There's a QR code attached to that, isn't there?
Yeah, you can.
I think what we'll also do is we'll put that on our Gastro Learning site, so that people who may be reviewing this tutorial at a later date can go and see that, because I think that's going to be an area which will be of enormous use to endoscopists. Can I ask, again, on live courses, there can sometimes be the experts saying, oh dear, this lesion has been biopsied before referral, and then that is creating some difficulties with resection. The problem for the general endoscopist is that they may feel nervous about sending a patient to a tertiary center for what they visually think is a dysplastic lesion without pathological proof. Is it a crime to biopsying, small lesions? And if not, then what is acceptable?
Mm-hmm. Yeah, so it's definitely not a crime to biopsy small lesions. But we always, if you see an abnormality during your surveillance and you're not sure if it's dysplastic or not, I think the most important thing also is to make pictures of the lesion with white light, and if you have narrowband imaging, with narrowband imaging. And it's never a crime to take 1 or 2 biopsies if you're in doubt. So you don't have to take like 6 keyhole biopsies. That's a little bit not necessary, but 1 or 2 will never hamper endoscopic treatment, not as in the colon, or for example, squamous neoplasia. You get more fibrosis, but Barrett's is a little bit thicker. So 1 or 2 biopsies is not a problem. And even if you think that there is a visible lesion and the biopsy just shows low-grade dysplasia, for example, I think if you see something, even if it's very subtle, and you don't trust it, you can always send the pictures to an expert or someone who treats Barrett's, because we know that biopsies often understage visible lesions. So if there's a lesion, we prefer to take it out with endoscopic resection to be sure there's cancer.
That's incredibly helpful. And we'll move on to resection, but just clarify for us, ablation, what do we ablate? When do we ablate? What do we resect? And then we'll have some comments about EMR versus ESD in terms of resection. So ablation, who are the patients who we are ablating, and what are the optimal techniques for that at the moment?
Yeah, so I think the indications for endoscopic ablation therapies, so with the aim to eradicate all the Barrett's mucosa, it's the patients who have a repeated diagnosis of low-grade dysplasia and biopsies confirmed by an experienced pathologist, because those patients have a significant risk of progressing to high-grade dysplasia and cancer. So if the patient is still fit and has some years to live, and has low grade, those are the patients you can treat with ablation. If a patient has high grade dysplasia, that's also an indication for ablation treatment. And we also treat patients who had early cancer or high grade dysplasia who had endoscopic resection of the lesion. We know that they have an increased risk of progressing to or of getting metachronous lesions in the rest of the Barrett's during follow-up. So those are also patients where we advise to ablate all the Barrett's mucosa after the endoscopic resection. Yep. And there's some different ablation techniques available. And the one that's most studied and where we have most evidence on the safety and efficacy, that's radiofrequency ablation. That is it's safe. It has a very high rate of eradicating all Barrett's mucosa without too many complications. And this is, I think, a nice video where you see the balloon-based electrode that's used to ablate the Barrett's mucosa circumferentially. Usually the patients get 1 or 2 treatments with this device. You can treat quite long stretches, and then when they come back, they can retreat with the focal device, which you see here on the tip of the scope, to treat the gastroesophageal junction or any islands, and they usually need 1 or 2 ablations with that as well.
Nice, very good. Okay, thank you. That's great. And then what about you mentioned about resection, EMR, ESD. Everybody talks about ESD, you know, for everything these days. Is it the answer for lesions in the esophagus? What is the interface between EMR and ESD? Mm-hmm. What lesions what would be the criteria in which you would select one or the other?
Yeah. So what we practice is that, like EMR, we have done that for years now in the esophagus with really excellent results also in the long run. And that was mostly for the flat type lesions, for Paris type 2A, B, or C lesions. We don't really have a maximum size, because you can do a piecemeal resection with the usual cap-based EMR techniques. You can get out pieces of about 2 centimeters in diameter. And if a lesion is bigger, you just make adjacent resections until everything is gone. So it's safe and effective, I think, for 90% of the lesions that we pick up during surveillance in Barrett's esophagus endoscopies. And ESD is becoming more and more applied. And the indications now are usually the lesions that are very bulky, like Paris 1 lesions, because you can imagine, if you look at the video, that if you have a very bulky lesion that fills up the cap, so you will not be able to get a radical resection in the deep resection margin. So if it's very bulky, you can do an ESD, because that allows you to get underneath the lesion, no matter how big or bulky it is. And also, if you have a suspicion on submucosal invasion of a lesion, based on the appearance or vascular pattern, those are also the lesions where we prefer an ESD, because that allows you to get a radical en bloc resection, which makes histological assessment of the specimen easier. And of course, a couple of years ago, all the patients with submucosal invasion were referred to the surgeon. So if you took it out in piecemeal, it didn't really matter, because if there was submucosal invasion, they had additional surgery or chemoradiotherapy. And nowadays, we know that the patients with submucosal invasion, if you select them well and follow them up well, in some cases, surgery is not really necessary. So in those cases, it's best if you get the lesion out in one piece. Okay,
very and similar complication rates, similar outcomes.
Mm-hmm. Well, ESD it's more difficult there's a longer learning curve, I would say. I think it helps if you have experience with EMRs, because then you know how to treat complications. And the most common complications of both techniques are bleeding, of course, but the risk is about 5% in the esophagus. And perforation is the other risk. I think for the EMRs, especially if you take a band ligation technique, that risk is really low. It's less than 1%. And for ESD, if you look in literature, the perforation risk is a bit higher, but that's probably more because it's a bit more difficult procedure. I think in expert hands, it's also quite safe. And the literature has higher rate of strictures when doing ESD, but that's probably more because you take out bigger chunks in one piece.
Okay. Yeah, and I was going to ask about the long-term benefit and including ablation of Barrett's, the maintenance of that response, but also some of the long-term complications, including strictures with ablation. You've mentioned about the short-term bleeding and perforation with resection techniques, but can we cure Barrett's? Straightforward question.
Yes.
Easy question.
Yeah.
So yes, we can. Is that the answer? Or
yeah, if you find it, you can you can remove it, and then we know that in the majority of patients during long-term follow-up, the risk of recurrence is very low. So most patients, if you resect visible lesions and then ablate the rest of the Barrett's, and then of course keep the patient under PPI, because that's the trigger, of course, that the reflux is what caused this all years ago. So if you take away the trigger and you remove the Barrett's, then the long-term outcomes are really well. And then I think you've cured the Barrett's. Yeah.
I was interested in those graphs refer to follow-up in days, which maybe we would be keen on sort of years probably. But we've got a couple of questions from, which I'm sure is available. We've got a couple of questions from the audience that have come through. One is, I've been told to stop treating low-grade dysplasia. Is that right?
Well, I think that depends a little bit on several. So I would not stop treating all Barrett's with low-grade dysplasia. I think you should only embark on treatment if the patient really has multiple, like at least 2 occasions, separate occasions with low-grade dysplasia, confirmed by an expert endoscopist. And of course, if the patient is 80 years old, then you don't have to treat the patient. But if he or she is fit and still has a life expectancy of 10 to 20 years, then I would treat the patient. Okay,
and APC, ablation techniques. APC, it's cheap. Most of us got it in our endoscopy units, and we're not using it for much else these days. So should it be used for the treatment of Barrett's?
Well, I think the results with RFA are much better. APC, well, we all know it because you use it for other applications, but it's very operator dependent, because RFA is quite easy if you do it. The effect is every time very consistently. With APC, it's very operator dependent. If you have a very short segment, of course, it's fine, but treating a long Barrett's can be difficult. Yeah. From older studies, we know that there is a higher risk of not completely eradicating everything, but usually I do use it as a touch-up after RFA and the patient has small islands of Barrett's. I do use APC to eradicate those. Okay, and can we get back to the simple stuff, which is pills and tablets? Tell us a bit about the ASPECT trial and where medical therapy sits in the management of Barrett's. Mm-hmm. I think the thing that's really evidence-based is that these patients benefit from PPI treatment, of course, before they are treated with RFA, for example, and even after, because the reflux is what triggers the Barrett's and the progression in the Barrett's. So if you control the reflux with PPI, I think that's the most important thing. And in the ASPECT trial, patients were randomized to different doses of PPI, low dose, high dose, and to aspirin, yes or no. And that's quite large study, didn't show any benefits of aspirin in terms of prevention of cancer. So there's not a chemo preventive agent we know yet for Barrett's. There are some suggestions from other studies that statins might reduce the risk of progression, but it's also a little bit of circumstantial evidence. So I think we don't have any real proof except for the PPIs.
And so patients, once one's made a diagnosis of Barrett's, every patient goes on to maintenance PPIs. What do you do after you've successfully ablated their Barrett's lining?
Yeah, we tell them to take their PPIs lifelong.
Okay.
Usually we give it 2 times a day. Experience learns that most patients will then end up with 1 time daily. Okay. But we do tell them that the PPI is the most important thing to prevent the Barrett's from coming back.
Okay. We're going to be out of time quite soon, actually, but a nice questions come through on the asking for your view on the endoscopic management of deep submucosal lesions. Mm-hmm.
Yeah, so we're currently running a study where we include all the patients who had a radical endoscopic resection for a submucosal cancer, even the deep ones. We restage them. We do endoscopy and EOS and the CT scan or PET-CT. And if they don't have any residual cancer in the esophagus and no signs of lymph node metastasis or distant metastasis, we include them in a protocol where we follow them quite rigorously every 3 months with EOS and gastroscopy and the CT after a year. Because we don't really know what the risk of metastasis is in these patients. Literature says 46%, but that's all based on surgical studies. More recent studies say it's more around 16%. So the guidelines still say deep submucosal invasion warrants surgery, but I think this field is changing and we might be able to predict better which patients you should refer to the surgeons and which patients we can keep under endoscopic follow-up.
Great.
But I think the restaging and discussing these patients in your MDT with the surgeons and the oncologists, etc., that's and of course discussing it with the patient is still the most important thing.
Brilliant. Nearly out of time. I'm just going to ask you where sort of 2 questions roll into one. How do you see the future of Barrett's esophagus care improving? What is going to bring about that improvement? Is it in the hands of the tech industry? Is it in the hands of the endoscopists like yourself? What is going to be the couple of things that are really going to advance care over the next 10 or 15 years?
Well, I think for what's going to be really interesting is the artificial intelligence, of course, which we also already know from the polyp detection. There's some in the colon. There's some really nice studies going on detection of neoplasia in the esophagus as well. Of course, that goes hand in hand with the endoscopist because the computer can only pick up what the endoscopist shows. But I think the endoscopist will get better from that and we will pick up more very early lesions during surveillance. And I think we talked about the biopsies, of course, and the good question. I was told not to treat low grades anymore. Low grade is the best predictor we have for progression to cancer nowadays, but I think there's a lot going on also in the biomarker detection, etc. So I think in the future, we will be able to risk stratify patients better to see who has a higher risk of progression to cancer, and then we can be much more selecting in treating patients. I think better detection of neoplasia and risk stratification will really make a big change in the upcoming years. Great.
Wow, we're out of time, running out of time. What a fantastic 30 minutes. I have to say that I've learned so much in that session. So we will get you back, if we may, to talk to us further at a later date. But that really was great to have you with us. And I know that you're not only on a green endoscopy drive in the Netherlands, but a green transport to work drive. And I think you've whizzed home on your bike 30 kilometers to join us. So we're very, very impressed. So thanks ever so much for joining us. And if for people listening in, you can go on the Gastro Learning site and take this all in again, because there's lots to learn and a really great session. So thanks ever so much, Roos.
It was a lot of fun. Thank you, George,
Thank
for
you.
the nice chat.
Cheers.
Cheers.